Okay, well, thank you for that introduction. I don't know about world renowned, but I am a clinician. I do take care of kids with congenital heart disease, and I do it in the operating room and I do it in the ICU. It's a challenging job, and I have spent a big section of my career trying to figure out how to get more of these children to survive with their faculties intact, which I guess is the simplest way to say that. In my career, we've gone from 50% mortality for neonatal heart surgery to 97% expected survival for neonatal cardiac surgery. And the problem is we still have a 50% neurologic injury rate with that. And that hasn't improved with any of the advancements we've made. So that's really where I have put my effort in my career. And before I go on, I want to say I think Kathy could easily give this talk. Kathy and I worked together for 15 years on the technology that I'm going to present. I'm going to say that it's really unfair for me to take credit for what I'm about to show you. And I would say that, none of this would have happened without Kathy. And you're going to see it's pretty cool stuff. So thank you, Kathy. I think you're going to like it. And I just want everybody to know Kathy was as much a part of this as I was. For 15 years, we worked together in the lab on this stuff. So let's start with the problem. I don't know what you guys like to do in your spare time, but mostly with my spare time, I go backpacking in the mountains. The reason I go backpacking in the mountains is because no one can reach me for the week that I'm there. I can't be reached at all. I'm in deep in the wilderness, and I get as far into the mountain range in the wilderness as I can. And it's fun because my daughter likes to do this with me. And one summer, we did it for 30 days. We did the entire John Muir Trail, if you're familiar with that. And that was just fantastic to do that with my daughter. And one night we were at an elevation where we were allowed to have a campfire. And so we had been slogging it out on the trail all day and sitting around a campfire. And she asked me, "What do you like the least about your job?" So how do you answer that? Right? My 16-year-old daughter is asking me, what do I like the least about my job? Think about it. What would you say? I didn't even blink. I said, the thing I like least about my job is when I do something that hurts a child. And then I have to go live the rest of my life knowing that I did that. And every time it happens, it's like somebody adds this extra load you have to carry for the rest of your life to the load you're already carrying. And I have probably saved thousands of kids' lives. I've resuscitated how many babies from death, right? I can't remember any of them, but I can remember every single mistake that I made that led to a bad outcome for a child. And the other thing about this is knowing that the care we give is still not perfected. We still are flying blind. We're still flying without instruments. We are still making decisions, thousands of decisions every day. I came out of the ICU to come give this talk. I made 200 decisions today. Were they the right decisions? I mean, half of them, I don't really know the answer, but knowing that 50% of these babies have brain injuries at the end of our care, and 50% of the teenagers who survive what we do have measurable developmental deficits because of what we did, that's sobering to me. So here's a kid, 5 days old, hypoplastic left heart syndrome, post-op day 1 from a Norwood. This is what I do every day. Has a Blalock-Taussig shunt. His blood pressure is 58/24. The mean pressure is 32. SAT's 85%. Warm toes, brisk capillary refill. ST segments are stable. Who's going to treat that blood pressure? Who thinks that's enough blood pressure for a 5-day-old with hypoplastic left heart and a BT shunt? Who thinks that brain's adequately perfused? Who thinks that brain's not adequately perfused? Show of hands. Anybody want to treat that? Okay, well, when I was a fellow, I treated that, and I got my hand slapped because I was told by one of the people I respect the most in the field, David Nichols, and he said, I'm sorry, but if you raise the blood pressure of these kids with BT shunts, you're going to kill them. So as their toes are warm and well perfused, you leave that blood pressure alone. And that was that. I challenged it and I challenged it for the rest of my career. And I'm going to tell you why. We're going to go through three things in this. I'm going to talk about the differences in the perfusion of organs in your body. You have visceral organs, you have your heart, and you have your brain. Those three categories of organs are not perfused by the same rules. We only get one cardiac output and you only get one blood pressure, and we're so focused on that, but that does not describe the perfusion of the organs in your body. And how your brain perfuses and how your kidney perfuse are so different that they're at odds with each other. And what you do that improves the perfusion of the brain might make the kidney worse and vice versa. And I'm going to go into that. I'm going to explain that. I want to talk about this curve. Everybody should be, can you see that cursor there? Yeah. Everybody should be familiar with this autoregulation curve. This is blood flow as a function of blood pressure. And you have this range where blood flow to the brain is autoregulated because it doesn't change as blood pressure changes. Then you have this lower limit of autoregulation where if the blood pressure gets any lower than that, blood flow to the brain falls. And then you have this critical closing pressure, which is the blood pressure at which flow goes to zero in the brain. I'm going to talk about why that curve is important and how we can actually know in real time where we are on that curve. I'm going to say that again. It is possible to know in real time where you are on that curve while you're taking care of the patient for that individual patient's brain. And that's the technology that Kathy and I worked on, and that's what I want to talk about. And then I want to talk about the idea of clinical proof of this idea and what we have and what we need. So let's look at this preterm brain. Not the preterm brain, but the brain of the child with congenital heart disease. If you can see, this is the survivor of neonatal heart surgery, and these stripes along the white matter next to the ventricles here, this is periventricular white matter injury. That's the classic injury that a child with congenital heart disease gets after surgery. And I'm going to say the number again, it's 50% have this. So that is associated with developmental abnormalities. And that's the thing we're trying to prevent. What is that? Why do they get that injury? Why do they get it there? It's not an embolus. It's a watershed injury. That's the watershed region of the brain first. And preterm neonates have a lack of redundancy of the arterioles that go into that portion of the brain. And that redundancy develops with time. Children with congenital heart disease are born with immature brains. So connect the dots. They lack that redundancy. The oligodendrocytes that live there they're at a state of differentiation which imbues them with increased sensitivity to ischemia. They're actually more sensitive to ischemia than the neurons are. And so that's why that watershed area, which is full of ischemically sensitive oligodendrocytes, suffers the hit from ischemia. When I put all this together, that's a smoking gun. That's not, this means when we had control of their perfusion, we turned all the dials and all the levers. We chose their blood pressure. We chose their output. We chose everything about their perfusion. We chose wrong, and we gave them a watershed injury. That's what that means to me. And I was going to go into that, but I guess we could. It's obvious that the more complex the congenital heart lesion and the more hypoxic the heart lesion, the more likely they are to develop these injuries. That's kind of common sense. But so you might say, hey, let's prevent this from happening. Let's jack up the flows and jack up the pressure. Easy, right? It's a watershed injury. Just raise the blood pressure, like I said when I was a fellow. Well, the problem with that is, think about the 1990s. When in the 1990s, I took my first call in the pediatric ICU as a pediatrics resident, and my attending, I said, there was a hypoplasty who'd had a Norwood. And I said, I don't even know what this operation is. What's going on here? Tell me, what am I supposed to do here tonight? And my attending said, do you have a coin in your pocket? Take it out and toss it. That's the chances this kid will be alive in the morning. And my attending went home, had no expectation for this child to live. People just didn't know what they were doing in the management of these kids. Well, how did we go from that coin toss survival to now? Every single one of them is expected to survive, and the outcomes are published, and we fully expect them to survive. One of the things that happened was in the 1990s, we started putting phenoxybenzamine in the pumps for these kids. And what was happening is they would come out of surgery so vasodilated that you couldn't apply vasoconstrictors to them. And the reason that's beneficial is because they have these shunted lesions where when their SVR goes up, they don't necessarily improve perfusion of anything. They just shunt more blood down their pulmonary vascular circuit, and they get less blood to their body. And so keeping their SVR low allowed them to balance their circulation and get more perfusion to their body because of that shunt. That was a big piece of getting them to survive, was stopping the SVR increases in these babies. In addition to that, when you do afterload reduction on a neonatal heart that has just gone through bypass, it has a bigger stroke volume. You get more cardiac output. You get less SVR, gives you better visceral perfusion. Your QPQS ratio is more balanced, as I said, less acid production. And these are the things that sort of that compound into leading to the perioperative arrest. So we watched the perioperative arrest rate just melt away by putting phenoxybenzamine into the pump. And that shows how important it is to keep the SVR down. And that's a barrier to raising the blood pressure and raising the brain perfusion. So why doesn't that afterload reduction help the brain? Because the brain doesn't care what the cardiac output is. The brain is not affected by the cardiac output. The cardiac output can be low, normal, or high, and the brain gets the same amount of blood flow. It just takes it. And if the only thing that affects the perfusion of the brain is the blood pressure. If the blood pressure is high enough, the brain autoregulates and gets the exact right amount of flow. And if the blood pressure is not high enough, then it doesn't. And this has been shown here. Here's baboons on bypass with baseline flow to the brain, low flow, full flow bypass, and low flow bypass, and then the same flow rates at low blood pressure. So full flow doesn't protect the brain from hypotension. High cardiac output perfuses the kidney and the gut, but it doesn't perfuse the brain if the blood pressure is low. So there we are in this conundrum with these fresh neonatal cardiac surgeries. Am I going to have enough blood pressure for the brain, or am I going to have enough cardiac output for the gut and the kidney? That's the conundrum. Here's an experiment Kathy and I did where we took a piglet and we put them on full flow bypass. The entire experiment is conducted at full flow. And then we lowered the blood pressure with vasodilators. And you can see the blood pressure lowers over 4 hours. Here's the flow to the brain measured by laser Doppler that drops when the blood pressure gets too low. That's at full flow. And then here's the oxygen tension in the white matter measured with a Lycox probe, which also drops. And then you can see these autoregulation curves that formed. The entire autoregulation curve, this is blood flow as a function of blood pressure. This is oxygen tension in the white matter as a function of blood pressure. That entire curve is at high flow, higher than normal flow bypass. So again, I'm going to just say it, high flow doesn't protect the brain from ischemia if the blood pressure is inadequate, period. You get tons of flow to your skin and your gut and your kidneys, but not for the brain. One more example of this, here's a piglet where we induce low cardiac output, and the blood pressure slowly falls over 4 hours as they get lower and lower and lower cardiac outputs. So initially, the brain does nothing. The flow to the brain stays constant, and the blood pressure doesn't change. For hours into this experiment, the blood pressure is unchanged, and the flow to the brain is constant. But what happens to the kidney is before the blood pressure ever changes, the blood flow drops to less than 25% of its baseline value. So again, my cardiac output is falling. My blood pressure hasn't changed at all, but my kidney is getting 25% of its baseline blood flow, but the brain sees none of it. The flow is a constant, unchanged. Until the blood pressure starts to fall, then when you reach the lower limit, the brain loses flow because it's lost autoregulation. But by that time, the kidney's already completely shut down. It's down at 10% of its baseline flows. So I think I'm going to skip this for time because I think we're running a little behind, but you get the idea, right? That which is good for the brain is not good for the kidney, and that which is good for the kidney is not good for the brain. And when you add an aortopulmonary shunt to that math, you amplify that problem. So here's our conundrum for these babies. Are we going to give them enough blood pressure to perfuse their brain and still have enough cardiac output to perfuse their kidney? And how do we know how to do that? Well, I would say if you don't know if you're going to lower the blood pressure to get better perfusion of the kidney by giving a vasodilator, which we do every day for every one of these babies, that's how they live. If you're going to do that, you have to know where the lower limit of autoregulation is, because that's how far you can push the blood pressure down. And if you go farther than that, guess what you're going to get for that? You're going to get a watershed injury in the brain. So how do we lower afterload but preserve cerebral blood flow? You do it by knowing where that break point is. Where is that lower limit of autoregulation? Now, I don't need this blood pressure. I can lower the blood pressure to here. But if I lower it to here, I'm going to have a problem. Easy to state the problem. How do we monitor that? How do we monitor blood flow? I'm gonna move past this quickly as well. This is the early attempts at this, and they didn't work. This was done in the 90s. People tried to use transcranial Doppler to do this. It just didn't work. It didn't answer the question. No change in practice occurred because of it. And then there was this new idea. Instead of monitoring blood flow itself, it's just a slippery target. Blood flow goes up and down with changes in temperature. Blood flow goes up and down with changes in metabolic rate. You don't know what normal flow is for any given state, and it's hard to target a flow in the brain. But instead of measuring flow itself, what if we measured the brain's ability to regulate its own flow? What if we measured autoregulation itself? What if we measured the reactivity of the blood vessels in the brain and then look for the blood pressure where that reactivity is present? Because if the brain has reactive blood vessels, it's going to regulate its own flow. And then look at a blood pressure at which that reactivity gets lost and that autoregulation gets lost. And this is my mentor, Marek Shostka. He's a physicist at Cambridge University. He taught me how to do everything that Kathy and I ended up doing in the lab. And he was using intracranial pressure waveform analysis. Obviously, we can't put intracranial pressure monitors in our patients, but the physics and the math and the waveform analysis that he developed is exactly what we used in non-invasive metrics to do the same thing. So let me show you how that works. This is his method. There's the blood pressure at the top. This is a piglet in our lab with normal blood pressure. And you can see that this blood pressure has been filtered out to get rid of all the pulse waves. So you see this mean blood pressure, these are 5-minute, each one of these little waves is like 5 minutes long. And a lot of people don't realize that mammals have these waves in their blood pressure because they're not that big. And until you filter out pulse and filter out respiration, you don't see them. But all mammals have these low frequency waves in their blood pressure. And what's interesting about them is if you look at the intracranial pressure right underneath it, you notice that it's exactly inverted relative to the blood pressure. So that's not an accident. The blood pressure is going up and the ICP is going down, and the blood pressure is going down and the ICP is going up. So why is that? It's because if the blood pressure goes up and the flow is going to stay constant, all the blood vessels have to constrict. If the blood vessels constrict, the ICP drops because the blood volume in the brain drops. And if the blood pressure goes down, all the blood vessels then dilate. That raises the blood volume and increases the ICP. Is everything okay? Yeah? Okay. So what happens is in a healthy state of autoregulation, the blood pressure and the ICP are going opposite of each other like this, inverted. So if you want to mathematically quantify that, you can make a phase angle and measure the phase angle between those two waves. Or you can just do a correlation coefficient, which is what Marek did. And he ran a continuous correlation coefficient measuring the relationship between this wave, a specific wave of blood pressure, and ICP. And he showed that patients who had a negative correlation survived and patients who had a positive correlation died after head trauma. Now, what I've got on the next row here is blood volume measured with near-infrared spectroscopy. And that's really what Kathy and I worked on a lot. We figured out a way to use reflectance spectroscopy to measure the density of hemoglobin in the tissue to recreate the waveform of the ICP We don't know what the ICP is, but we know it's going up, it's going down, it's going up, it's going down. And then we were able to recreate Marek's metrics using near-infrared spectroscopy to do this without an ICP monitor, because it doesn't actually need to be calibrated. You just need to know the timing and the directionality of the waves, and that's what we were able to do. Well, we take this same piglet, and then we lower their blood pressure below the lower limit of autoregulation. And now look at the relationships. It's no longer inverted. Now when the blood pressure goes up, the blood volume gets pushed up because the vessel doesn't squeeze shut, it gets pushed open. And when the blood pressure goes down, the blood volume drops because the blood vessels don't dilate, they collapse. So you've gone from a reactive state to a passive state, and it's something you can measure and it's something you can quantify. And guess what? If you do it continuously, you can delineate for an individual patient a range of blood pressure where the reactivity state, where the correlation is negative, which indicates reactivity, and where the correlation is positive, which indicates passivity. This is a four-year-old child who fell off the back of a motorcycle and was in our ICU for 10 days getting treated for head trauma. And this is that child's autoregulation curve. And you're looking at, if his cerebral perfusion pressure was kept here, he had reactive blood vessels in his brain. And when his blood pressure drifted down here, he lost reactivity. So in real time, that patient, we knew their autoregulation curve. And there's a ton of head trauma data showing that if your blood pressure is kept here after head trauma, you're more likely to survive and you're more likely to have a good Glasgow outcome score. And if it's down here, you're more likely to die. And if it's up here, you're more likely to have a very poor Glasgow outcome score. Lots of data showing that. I'm gonna talk a little bit about how we validated it. First off, how do you make a gold standard for autoregulation? Is there such a thing? How do you measure autoregulation, and how do you make a gold standard for that? There wasn't one. We searched the literature, and the available things to measure and study autoregulation were simply too crude. And what we had developed was much more finely tuned than anything that was in the literature. So we decided to make a gold standard that would just be obvious so that the reviewers would accept it. And what we did was we did these models where we would take these piglets and put a flow probe on the surface of their brain. And then we would continuously measure flow in their brain, and then we would slowly drop their blood pressure, and then we would plot their blood flow as a function of perfusion pressure, and we would calculate this inflection point, and we would say that inflection point is the gold standard lower limit, and then we could compare the metrics we were devising against that. And that flew with every paper we submitted. The reviewers accepted this as a gold standard, even though we made it up. There was no such thing as a gold standard. So that was kind of fun because Kathy and I made that up. One of the things that's important, a lot of companies are making these now. And I don't want to get too deep into this, but not everything works. Not everything that makes sense works. We actually measured the sensitivity and specificity of the different measures that we made, instead of just asserting that this works. And the thing is that you can have something that's statistically significant without being very clinically useful. And if you look here, like there's a lot of statistical significance going on with these different ways to measure autoregulation. But if you look at the actual sensitivity and specificity, there's only a couple that pass muster. And the problem is that a lot of the companies that are doing this now, and it's really disheartening after all the work we put into it, are using methods and metrics which we published don't work. I don't understand how that happens, but there you go. We put it all out there in the public domain for everybody to use, and it's just weird to watch. All right. One thing I did say, you can't drill a hole in an infant's skull and put an ICP monitor in them. And so how did we make this work for bypass? And I did mention that we did these metrics using infrared spectroscopy to recreate the ICP waveform using NIRS. And it's not the RSO2 or the cerebral oximetry you're used to. It is a different thing, but it's very similar. It uses the same wavelengths of light. And we just basically quantify the density of hemoglobin in the tissue continuously. And you can see here, there's the ICP and there's the hemoglobin density. And you can see that all these slow waves, which are what's used to measure autoregulation, are perfectly recapitulated in the infrared measure. And then when we look at the receiver operator characteristics for the sensitivity and specificity, this is the receiver operator characteristic for Marek's, my mentor's invasive monitor, and this is the non-invasive near infrared based monitor. And with something, we've made this a little bit better since then using some filters and different things we've worked on. But even from the beginning, this early original experiment, it was very promising. This is the same piglet study I showed you. Remember, I showed you this piglet. We lowered their blood pressure. We made an autoregulation curve using flow. We made an autoregulation curve using oxygen tension in the white matter. And this is the non-invasive autoregulation monitor using near infrared spectroscopy. And you can see, above this red line blood pressure, this is reactive. This is intact autoregulation. And below, all these values are positive, indicating positive correlation, passive relationship between the blood vessels and the blood pressure. Blood pressure goes up, the blood vessels get pushed open instead of reacting the way they're supposed to. And you can see that it tells you that's the lower limit of autoregulation. Well, how would you use this? It seems obvious, right? If I'm on bypass and I have this curve sitting in front of me, which has been collected while I'm taking care of the patient, I can see that I need the blood pressure to be above that red line. And guess what? That's how low I can go and not have a problem in the brain. It's so obvious. It almost doesn't need to be tested, but of course it does need to be tested, and we did. The most important study that has been done on this was done by Chuck Hogue and Charlie Brown. And I'll just be honest about this. I submitted a grant when I was at Johns. You're gonna laugh. Kathy's gonna laugh at me. I submitted a grant when I was at Johns Hopkins, and when we first started doing this, I was still a fellow, and I asked for NIH money to be real important and do this big study because I had found this thing that I thought was so exciting, and they gave me these awesome. I got the pink sheets back, and I got full credit, full scores for the impact of it and the what did they say? It's not the originality, but the novelty of the science. And like there were 5 categories, and I had 100% on 4 of the 5. And then when it came to the investigator and their confidence in the investigator, I got like a 0. And so the thing got, there was no chance of it ever getting funded because they just weren't going to fund me. And I came to terms with that, and I found Chuck Hogue, who is a full professor and was a full professor at Johns Hopkins at the time. And he very kindly took an interest in what I was doing. And we took that grant that I had written, and we took my name off of it, and we put his name on it, and we took pediatrics off of it, and we put adult on it. And instead of asking for $250,000, we asked for $4 million. And then guess what? First submission, it was the best scored grant in the section, and there we were with $4 million to do this study. And I'll admit up front, there was a design flaw in the first iteration of this study, and we wanted. So what are you going to do? It's obvious. You're going to randomize patients to have the monitor visible to the perfusionist or not. So the perfusionist can see the lower limit, and then the perfusionist is going to have study patients or control patients where they can't see the lower limit. And then we're going to look at what they do and how they manage them different and how much their blood pressure goes below the lower limit versus the other group. So that's going to tell us feasibility. And then we're going to look at what outcome. And we said, of course, we're going to get MRIs. And that was the stupidest decision in the world because the preterm or the congenital heart disease patients have watershed injuries, but the adults have embolic injuries. And this isn't going to change the rate of embolic injury. And so it was the dumbest metric to put on there. And it turned out to not be different between the 2 groups in terms of the MRIs. But the study was rescued by Charlie Brown. Charlie Brown was studying delirium at the time at Johns Hopkins, and he knew we were doing this study, and he says, let me tag on to your study. I'm going to quantify delirium in all of these patients postoperatively. And he says, this is a gold mine because there's a 50% incidence of postoperative delirium in adults having cardiac surgery. So let's see if keeping their blood pressure above the lower limit changes that. And so he nested his study within that. And so there were two papers that came out. One said there's no difference in the MRIs, but then the delirium study is another story. And this is very important. So there were 200 subjects enrolled in the delirium study. 105 of them were in the autoregulation group and 94 were in the control group. And then we looked at the safety. We looked at the safety during this. Let's start here. In the larger study, in our safety monitoring data, 140 were in the control group and 140 were in the autoregulation group. And we had less dialysis, less kidney injury, less sepsis, less ventilation, less multi-organ failure, less use of inotrope, and less death in the group that had the autoregulation monitoring. We couldn't really do anything with that because it wasn't our hypothesis. None of that was our hypothesis. We didn't think any of that would be different. But we can at least conclude that it is safe to monitor autoregulation and manage blood pressure according to the lower limit of autoregulation. I can say without blinking that it is safe to do in adults. I can't say that it improved, that's it's better for mortality because that was not our hypothesis, but for safety analysis, it was. Is it feasible? Well, if you look at the differences between the autoregulation targeted and the standard care groups, there was a little bit more phenylephrine use in the autoregulation targeted group. And doesn't that make sense? If somebody sees that their blood pressure is below the lower limit, you give them a little shot of phenylephrine and their blood pressure goes up. So of course they got more doses of phenylephrine during their pump runs. Their mean pressures, interestingly, were not terribly different, even though it was statistically significant, 74 versus 71. I think that's interesting. And also it's weird because the study started where all the subjects' mean pressures were 55. And by the end of the study, all the subjects' mean pressures were in the 70s. So it drifted up because people started to learn where the lower limits of autoregulation were for their patients. And they started changing how they were managing the control subjects, which that's not great for the study, but it is an interesting finding. And then when you look at the magnitude and the duration of blood pressure excursions below the lower limit, that's the question of feasibility, because it asks this question: how long does it take to figure out where the lower limit is by this monitor? And do you learn in time to do anything? And if you do know that you're below the lower limit, is there anything you can do to get their blood pressure above? So we already showed that that was safe. But is it feasible? Do we actually have less exposure to blood pressure below the lower limit if we know where the lower limit is? And in fact, it was nearly cut in half, meaning the magnitude of the depressions of blood pressure and the duration of the depressions in blood pressure below lower limit were half in the group where the provider knew where that lower limit was. So it's safe and it's feasible. And then in terms of the delirium outcome, there was a 30% reduction in the incidence of postoperative delirium, and that was a hypothesis question. So we can say that the use of autoregulation monitoring in this randomized controlled clinical trial was safe and feasible, and it was effective at reducing the incidence of postoperative delirium, and by a clinically significant amount. It was a significant magnitude of reduction. So that was great. We drank a lot of beer to celebrate, and it was wonderful, but it doesn't really help me. I'm not taking care of adults having mitral valve replacements and cabbages. I'm taking care of neonates with immature myocardium that doesn't like getting stepped on with a bypass run, and aortopulmonary shunts that steal systemic blood flow and are very sensitive to increases in SVR. I can't just squirt a bunch of phenylephrine in a Norwood and expect that to go well. So this study, while it was fantastic, I found, disappointingly, it didn't bring me any closer to what I'm trying to do. And so we're working on, I gathered up a group of world-renowned experts that I can get a good NIH grant with. Some of you know Dan Licht and Brad Marino and Ashok Panagrahi. They're the who's who for congenital heart disease neurologic studies. And so we're working on recapitulating this, and we're going to look at the same feasibility question. If we know the lower limit for these neonates on bypass, can we reduce the burden of blood pressure below that lower limit? Is it feasible? And then we're going to look at safety for them. And I think it's going to be a much more important question to look at the same safety metrics in these patients, because it may not be the same. It may be very dangerous to raise the blood pressure of a newborn having cardiac surgery. And then for efficacy, what are we going to do here, right? You can't measure delirium in a post-op neonate. Who's the president, right? What year is it? How's that going to go, right? Are they going to poop their pants? Oh, okay, they're not delirious. So we win. That doesn't work. And the MRI findings probably are better because they are watershed injuries. They're not embolic. So that's probably a better way to do it, but it's also, it's onerous and it's challenging to take a fresh post-op neonate and slide them in an MRI scanner and not have an event. So that's a difficult study to carry out. And then the other thing we were looking at is whether we can use seizures, because there's a 15% incidence of postoperative seizures. And those seizures are highly linked to developmental abnormalities, so very clinically relevant. And if we could see if there's a reduction in the incidence of seizure, the problem is at a 15% incidence, your sample size goes way up compared to a 50% incidence of delirium. So it's a challenging study, but we're doing math and we're gonna work on it. So I thank you very much for your attention, and I hope it was enlightening.